the initial assessment was that the eye's okay, but there's just a tiny spot on the skin of the eye that suggested something had hit it. And being the nature of the item, i.e. a very high velocity drill bit, very high index of suspicion, and there was indeed a tiny fragment of drill sitting inside the vitreous jelly.
It's safe to say that today's expert guest is one of the only very few experts in his field. It has taken many years to develop the skill set he now possesses and uses every day to help people with their eyesight. Mr. Andrew Davies is a consultant ophthalmologist and vitreoretinal surgeon, which means he specialises in surgery at the back of the eye. He specialises in all aspects of vitreoretinal surgery, cataract surgery, including both complex surgery and the complications of surgery, and medical retina conditions. He completed his 7-year ophthalmology specialist training programme in the Northwest Deanery, predominantly at Manchester Royal Eye Hospital. During his training, he completed the fellowship at Moorfields Eye Hospital in London, followed by the Vitreoretinal Fellowship at Manchester Royal Eye Hospital. Andrew is also an honorary clinical lecturer at the University of Central Lancashire for the optometry degree, and the college tutor for the Royal College of Ophthalmologists, and he regularly teaches locally and nationally and has published multiple journal articles. And he takes pride in training the next generation of ophthalmic surgeons. Mr. Andrew Davies, very warm welcome. I'm delighted to have you on the show.
Thank you, Lev. An absolute honour to be here, and thank you so much for inviting me. This is very exciting.
Brilliant. It's great to have you, and I look forward to this conversation. And now, for those of you who haven't listened to this podcast before, you should know that at the end of the podcast, I turn control over to Andrew for virtually the Virtually Anything Goes question. This is where Andrew gets to ask me questions, or at least one question. It doesn't have to be related to today's topic, and I will have to answer it no matter what it is. I won't know what the question is before Andrew asks it, but the only caveat is that he will have to also answer the same question after I've given my answer. And of course, if you like today's episode, please help us grow this podcast by liking and subscribing to it and sharing it with someone you think would like it too. So, Andrew, you told me I can call you Andy as well. Let me start with this question. What is vitreoretinal surgery, and how do you get into this specialised field?
Great question, Lev. So vitreoretinal surgery is, as the name would suggest, surgery to the vitreous and the retina. Now, obviously, to understand that does require some understanding of the anatomy of the eye. And it's quite difficult to explain through a podcast. So we have got a photograph here to aid those that are watching, showing a cross-section through the eye. And if you think of the eye as being like a sphere or a tennis ball, then the centre of that is filled with the vitreous, which is a very thick, gloopy jelly. And then the retina is the lining of the back of the eye. And we operate essentially on any condition that can affect the retina or the vitreous that would benefit from surgery. And this photograph that also is here shows how we get into that space through these very fine instruments through the wall of the eye. The eye is often compared with being like a camera. And we look at the front of the eye, we have the lens. And when I say camera, I do mean cameras of people of our generation and older, of course, because I think the youth may not fully appreciate this. But the lens is at the front of the eye, and we have a cornea and the actual crystalline lens, which both act in the same sort of way as a camera lens. And then the vitreous jelly, I suppose, is like the vacuum that separates the lens from the film. And the retina is very much like a camera film, where light travels through the lens, hits the retina, and this turns it into the images we see, because the retina is directly connected to the brain and is considered to be part of the brain, really. So that's the first part. And then you also asked me, how did I get into this? Yeah. And so as you go through ophthalmology training, you try all these different specialties, and I think the general public may not realise that in the UK in 2024 there is not really any such thing as the ophthalmologist that does every type of eye surgery. We are all so subspecialized, and we go through all the different subspecialties. And to me, I think vitreoretinal surgery, as we'll probably come on to later, a lot of the work that we do is unplanned and emergency work, and that kind of probably fits in with my character, really, of just somebody that doesn't like to have too much planned in advance, and you just deal with whatever's in front of you on that day or next week, perhaps. But I don't like to plan too far ahead beyond that. Yeah. I find myself quite quite calm in these environments of just not knowing what's going to happen that day. And I knew when I started doing it that as a trainee that this was what I wanted to do for the rest of my career.
Brilliant. I mean, just looking at that picture, I wouldn't be surprised if most people winced when they saw that. And I would imagine, and I think I sort of intimated about the beginning, there's not many vitreoretinal surgeons in general or in the UK. How many of you are there, and how does that compare to other areas of surgery in terms of the volume? Is it quite a small select group?
It's probably less than 200, about 150 of us are consultant vitreoretinal surgeons in the UK. Precise numbers are very difficult to pin down. I can't say exactly what proportion of overall ophthalmic surgeons that is, but probably less than 10%. The vast majority of eye surgeons will do cataract surgery. That's the bread and butter for all of us. But then beyond that, we all subspecialise in a sort of niche area, which VR surgery, as we abbreviate it to, is I think the most exciting one.
Okay, VR surgery. I'll use that one because it's a bit of a tongue twister for me, at least. But
yes, less of a mouthful, isn't it?
Yeah, exactly. So, I mean, we saw that picture, and for those who are listening to the audio version of this, it basically showed the kind of effectively, if I can paraphrase, the kind of the eyeball and very small, fine instruments going into that for an operation. When was this first performed? Because I mean, clearly that wouldn't have been possible. Probably even, I don't know, 100 years ago. When was it first performed, and excuse me, where and how? I mean, this must be quite a recent thing, right?
Yeah, so I mean, eye surgery itself goes back thousands of years, and I'm going to give you a little brief historical vignette because although it's not directly vitreoretinal surgery, I suspect 2,000 years ago there was a great need for vitreoretinal surgeons because probably the first operation was cataract surgery, and going back to, let's say, Roman times or even before that. But these days patients will have cataract surgery when they struggle perhaps to see their golf ball, or they might be getting near to the legal driving standard, but it's pretty high visual standards that people in certainly in the UK would have these days. But if you don't do anything about a cataract, and especially with poor diet and no sunglasses and things like that, cataracts can progress to quite severe levels. So you can be blind from it if untreated. And so in the olden days, a long time ago, surgery to treat a cataract was to get a very sharp stick and poke it straight through the cornea, through the front of the eye, and push the lens back into the vitreous cavity of the eye, which is where I now operate. So that's where eye surgery has come from. Thankfully, things have moved forward a lot. But retinal detachments, which is a significant part of my workload, they weren't really treatable until about 100 years ago. And then the first operations to treat that were not vitrectomies. It was more sort of external operations, pressing on the outside of the eye and trying to basically superheat the retina through the wall of the eye, which didn't have a great success rate, but did give some patients the chance of seeing. Mm-hmm. But modern vitrectomy surgery, and I think it's the first vitrectomy actually took place in 1971. So that's just over 50 years ago. And really over the last 50 years, there's just been such a dramatic increase in the safety of the surgery, the speed, the outcomes are so much better, all because of the instrumentation, the technology that goes with that, and also, I suppose, the learning. And every generation of surgeons will develop new techniques and then pass that on to the next generation. So the modern vitrectomy is, I suppose, 53 years old. I think it was first done in the USA by a surgeon called Makama, but it's just developed since then.
Right. And I mean, you just describe it, and obviously you say there is a lot of advancement in that. But I would imagine, if I came to you with an issue and it wasn't an immediate emergency where I had no choice, but I would imagine there'd be some common misconceptions around what people think has to happen, or how much it will hurt, or kind of just overall. What are the common misconceptions that people come to you with, and how do you address them? How do you put people's mind at rest?
Yeah, there's quite a few things that people are extremely apprehensive about having eye surgery, and also the majority of the operations we do, the vast majority we do under a local anaesthetic, so patients awake for these. Right. And I think understandably, people are often quite terrified about this. there's probably a couple of things that I can think of that really stand out, and I can pretty much knock these on the head quite quickly for the patient and put their mind completely at ease.
Right.
And the first is a misconception that we actually take out the eye to operate on it, like rest it on the cheek and then pop it back into place.
Okay.
And I can say categorically that that doesn't happen, partly because the eye is attached to the brain by the optic nerve, which does have a little bit of stretch in it,
Yeah.
admittedly. It has got a bit of give, but definitely not enough to put it onto the cheek. So that one's an absolute no-no. And then the other common one, when I tell patients that they're going to be awake for the surgery, is they are petrified at the thought of me coming towards them with a blade, a knife that they can see coming straight into their eye. And I don't know if you've seen the film Clockwork Orange, but some kind of torture scene like out of that,
Yeah.
where the eyes are pinned open and you have this knife coming straight towards you. And that's not the experience they have at all. During the surgery,
Mm.
the anaesthetic around the eye will just completely change everything they see, and it's quite unpredictable what they will see. Sometimes it just goes completely dark. Other times
Mm.
it'll go quite light. But there's a certain there's one comment that amuses me because it often demonstrates the sort of the patient's background, perhaps of they might see sort of kaleidoscope effect and bright lights, and they'll say, "I haven't experienced this since I was in Glastonbury in 1979 or something like that." And I don't sort of question what their experience was,
Yeah.
but so they'll see all sorts of things. But what they don't ever see is a horrible knife coming straight towards their
Right.
towards their eye.
Well, that will be. I mean, that was my thought as well. When I thought about,
Yeah,
what would the experience be? This needle coming towards you, or a knife, or whatever. So it's, yeah, I'd imagine they appreciate the fact that they won't see that. Um,
yeah,
so,
absolutely.
I mean, I mean, you spoke about a few things, cataracts and so on, but typically especially for the VR surgery, what kind of diseases or injuries do you treat most commonly? When is it needed?
Yeah. So we treat a broad range of conditions, but probably the biggest bulk of our workload, especially in terms of planning for the unplannable, is retinal detachments. And so probably about 35–40% of the operations I do are for retinal detachments, which often need to be done very quickly. So typically we aim to get certain categories of retinal detachments done within 24 hours. Others can wait a bit longer, but that's where the sort of unplannable aspect comes from. Um, so that's the bulk of our sort of day in day out work. Then there's all sorts of other things that can affect the retina as well. So that can be complications of diabetes, which can cause bleeding into the vitreous jelly, for example, or people can develop membranes across their macula, which is the very central part of the retina and the bit of our eye that we use for very fine detailed vision. So they can quickly develop quite significant symptoms from that.
Mm-hmm.
And so we are literally peeling off a membrane, often described as cellophane maculopathy, like cling film, off of the central part of the retina. You mentioned injury, and this is the bit that always makes me wince because we see lots of injuries. Now they're not the main cause of vitreoretinal surgery per se, but there are some. Sometimes we do have to do vitreoretinal surgery for patients with injuries, and I think I see danger everywhere. And when I say danger, I just mean danger to the eye. I forget about the rest of the body. And my children will attest to this as well, that in my mind, the most dangerous item imaginable is a pencil.
Right.
Uh, if it's held pointing upwards whilst running up some stairs.
Right.
um, so a pencil is a common cause of injury. Not common, but
Yeah.
a very unpleasant cause of injury.
Mm.
But perhaps the ones that can cause the most severe injuries, certainly in the northwest of England, not so much necessarily in other parts of the world, which might have more access to guns, for example, but the exploding drill bit
Yeah.
of people, especially those that might work in that sort of environment of drilling into a wall, and the drill bit might hit a bit of metal or something, and the drill bit will literally fly off at very high velocity.
Oof.
So much so that it might cause very little external damage
Mm-hmm.
to the eye because it's super hot and traveling extremely high speed. So it can travel through the wall of the eye without really leaving much of a wound at all. But then it enters the eye and can sit on the retina and cause all sorts of problems. And I'll give you one example, actually,
Yeah.
of a jeweler. So somebody that was drilling, making jewelry, and that the drill bit was must be sort of 0.5 millimeter wide, a really small drill bit. And they were doing something, and they felt something just pop on the machine, and then they felt like something just hit their eye, but they weren't sure if anything had hit their eye, and they looked in the mirror and they couldn't see anything, and they went to the hospital, and the initial assessment was that the eye's okay, but there's just a tiny spot on the skin of the eye that suggested something had hit it. And being the nature of the item, i.e., a very high velocity drill bit, very high index of suspicion, and there was indeed a tiny fragment of drill sitting inside the vitreous jelly.
Wow. Wow.
So,
Yeah, I mean,
wear safety glasses.
yes, that's the lesson here, I think. And if you know, if you're listening to this podcast episode and you're wincing but you're still listening, thank you for sticking with us, because you can picture these things happening and you don't ever want to happen for it to happen to you. But just you mentioned a few things that. Is what you do mostly damage limitation then, and you kind of fix things, or is it typically related to actual complete healing of whatever it is that you're working on? What's the most common scenario, and how effective is it then?
Well, the answer to that is it depends,
Right.
of course. So it really does vary a huge amount. So actually, a lot of the time, what we do is damage limitation. So it does depend on how advanced the condition is. So, for example, retinal detachments, they will typically the retina obviously lines the whole of the back of the eye. I'm just going to show you this photograph of a retinal detachment, which this is a photograph of the retina, and I'll try and describe it obviously for the listeners, those that aren't watching. But it should be a flat or rather concave surface. And it's sometimes also compared with being like wallpaper. So it's sometimes a camera film, other times it's wallpaper. Yeah. And the top half of this retina that I'm showing you a picture of is coming off, like wallpaper peeling off the wall. And we need to push it back into place again. Now, if the retinal detachment has started at the periphery and is progressing towards the center but hasn't reached the center, then if we get that back in place, then that surgery carries about a 90% success rate, which means one operation fixes it 90% of the time. And that patient should have perfectly good vision afterwards. They may need a cataract operation afterwards, but they should have perfectly good vision. If, however, it's just progressed that little bit further and taken out the center of their vision, then unfortunately at that stage, it's a much more what we say guarded prognosis, which means I can't guarantee what level of vision is going to be like, to the extent that all I can do is put the retina back into place, and then how much vision they get back, because at this stage the patient's lost their vision. They can see. They can see their hand moving. They might be able to count how many fingers I'm holding up, but they can't see much more than that. So we can put the retina back into place. We hope for improvement, and it should improve, but how much we just can't say. So that sort of thing is damage limitation.
Right.
Absolutely.
So I like the comparison to the wallpaper, because it's basically what you're saying is, similar to the wallpaper. If the corner peels off, you can stick it back on. But once it goes past the sort of half of the wall and it starts falling off by itself, then you need, it's.
And if you push it back up, if it's come off right down to the bottom and you push it back up, you're going to get creases in it, right? And unfortunately, the same sort of thing applies to the retina as well. And a crease through the retina, even if it's microscopic, so we can't actually see it, even when we're examining the patient, is enough to cause really bad symptoms. And that can not just be blurred vision, but symptoms of just distortion, which can be so frustrating for the patient. They might be able to see quite small letters, but there's a huge kink going right through it. And I really feel for the patients that have those symptoms, because we can't do anything about it, unfortunately, in most cases.
Yeah, it's really fascinating, and I'd love to dig in a bit more into kind of a typical day in the operating room, and what that looks like, and perhaps the challenges you encounter there. I mean, first of all, what happens? How does it all work in terms of how do you get ready and operate, and how does that look? But what are the challenges then might come across, and also what are the things that are most rewarding from the act of operating on an eye?
So the operating room, I mean, it's difficult to describe the whole environment, and of course every place is different. I'm very lucky where I work. We've got an excellent team that work with me, and they really understand the importance of what we're doing. It is a real team effort to get our patients through. And we operate, myself and my fantastic colleague, Emma Linton, we operate 5 days a week between the two of us, and we'll always plan to have some elective operations on there. So operations that have been planned a few weeks or months in advance. there's always space. There's always space for those extras that come in, and you can never predict exactly when they're going to be. So, I can be, for example, on a Monday, I typically operate. I do a clinic in the morning, and I will operate from about 1 o'clock till about 7 p.m. And I never like to start that operating list knowing that I'm going to be operating until 7 p.m. because chances are something will come in the afternoon that needs that, is probably best off being operated on the same day. So I always like to have some wriggle room. So we might start off with the sort of more elective procedures, and that might be the sort of epiretinal membrane that I talked about before. Okay, so that's something that the patient's been having symptoms for a while now that have been getting gradually worse. And then we might find that basically halfway through the afternoon lists, somebody from one of my colleagues from downstairs in our emergency clinic will come upstairs and say, I've got a macula on, I've got a MAC on RD, which means a retinal detachment where the macula is still attached. And or they just come and say, I've got a MAC on. And those two words are enough for me to know, okay, we've got to find space. Because that patient ideally should have surgery within 24 hours. That's the goal. Not all cases, but the majority, we aim to get surgery done within 24 hours. And so I immediately think, okay, we need to get this patient done today. And it's great because everybody else also understands the importance of that. And everybody really wants to stay home, stay at work late, and we try to avoid that because, otherwise staff burnout's a real risk. But they know that this patient needs surgery to save their sight, and it's fantastic to see that sort of kick into place. And so the patient gets sent upstairs. And in between two cases, I might pop out and see them and just explain what I'm going to do. They'll already been warned that they're going to have surgery with me, and then we get them done. And it's amazing to be able to provide that service.
Yeah, brilliant. I mean, those operations, and I suppose anything to do with the eye, is obviously extremely delicate. And we saw, that image with the sort of small instruments at the beginning. Talk us through kind of what the tools are that you use, because it's clearly not a massive scalpel, is it? I mean, these are quite fine instruments, aren't they?
Yeah, absolutely. So if we go back to that first picture I showed you, but I'll describe it as well, of course. So it's microsurgery or keyhole surgery. And so when I have medical students with me, I tell them it's a bit like a laparoscopic surgery, which is what my wife does, where they operate inside the abdomen with really quite big instruments. I say it's like laparoscopic surgery, but very, very small, teensy tiny laparoscopic surgery. So the instruments we use, we make holes through the wall of the eye, the sclera, which is the white of the eye, to an area that's just in front of the retina, so we avoid any critical structures. But these wounds are about 1 millimeter wide. And this is, again, where the technology's really transformed things just in the last 20, 30 years. Because the instruments need to be twice that size or maybe even bigger than that in diameter, not just in actual volume. So these instruments will, we need to illuminate inside the eye to see what we're doing because it's a dark cave otherwise, So one of those instruments is a very fine pipe. It looks like a needle, I suppose, but it's got a light on the end of it, and this is fiber optic cable, essentially shining light. We use the vitrectomy cutter, which again is the size of a needle, but it has a little guillotine on the end of it with a mouth, and that opens and closes 7,500 times a minute to suck the vitreous jelly out, but cutting it at the same time, because you can't just suck it out like an egg. That'll start to pull on the retina. You need to cut it as well. And then there's all sorts of other things, including a laser. So I get to use a laser beam, which is that's kind of appeals to my slightly more immature side of things, On an addition to that, I sometimes wear a laser beam on my head, which really appeals to the inner child. But so laser beams to secure the retina back into place. Microscopic forceps to pinch and peel those membranes off the macula, and this is just incredible, technology, material science that's led us to this stage.
Yeah, amazing. And I mean, we spoke briefly about it. Hearing all these things, I hope anybody listening to this will feel reassured that actually this is not some horrific experience, and actually is very technologically advanced. But I would suspect some patients will still be quite reluctant to, as we said, to undergo this kind of surgery. What's the experience actually like for them? You touched on a few things, but just in terms of coming into it, getting the anesthetic, what would the experience be like typically for a patient?
So I'll stick with the retinal detachment because it's such
Mm,
a important topic. And for these patients, I wouldn't think it's underplaying it to say it's a life changing experience because normally they're people that have got no problems at all in their lives. It's most common in about age 60 to 65, so it's often working age people who have had a healthy existence. There's typically no association with any other illnesses. And then it may be that last night they noticed that their vision was a bit funny in the corner and they woke up this morning and now they're missing half of their vision. And there's sort of realization that things are suddenly changing.
mm,
And then they go to hospital and they see, or they might see their optician in the first instance, who recognizes what the situation could be, refers to our emergency clinic, and they see one of our doctors there. And then they're referred to me upstairs in the operating theatre. And all this will happen in the space of a few hours. And by the time I see them, they're often a bit shell shocked, petrified, because
mm,
they can see themselves going blind. And it may be that they've got a problem in their other eyes. This is their better seeing eye, and all of a
right.
sudden their world is falling apart. So it's not uncommon to have patients in just really emotional situations. And I think part of the biggest joy for me, and I think for the team that work with me as well, is it's just supporting the patient through that, reassuring them. And I'm told that I do have a reassuring voice when I see these patients in the operating theatre environment. And if you ask that patient the night before, so tomorrow, do you think you'd let somebody stick some needles into your eyes and fiddle around with the back of your eye for an hour? And they'd think it's some kind of sick joke. But then by the time they are in this
Yeah.
situation where they realize it's a choice of having an operation or losing their vision completely, they accept that it has to be done. And there's this with that sort of situation, there's no option, certainly in most parts of the UK and many parts of the world, to give a general anaesthetic. So it has to be awake.
Mm,
And we have to just talk them through it, guide them. And sometimes we'd get one of our colleagues to hold the patient's hand through the surgery if that's what they want. And we all talk reassuringly.
mm,
We give them the choice of music that they want, or if they say they don't care, we just put on heart dance and enjoy some dance music. The patient's choice comes first, though.
yeah.
So it's a terrifying experience. Then they come in and we give the anaesthetic around the eye. That does cause a bit of pressure for a few seconds, but then after that, pretty numb. And then they're wheeled into the operating theatre. And this is a bit that can be tricky for some patients. Those with claustrophobia,
Mhm,
is we have to cover basically the top half of their body with a drape, a sterile sheet, just exposing the eye itself. Everything else is completely covered up to keep our instruments sterile. And this is where it does get tricky sometimes. There's patients, if they tell me that they can't get into a lift because of claustrophobia,
mhm,
I immediately alarm bells ring that we need to do everything possible to get this patient through. Be that sort of somebody actually holding the drape up as much as possible to let air go through. We do have a bar that supports the drape off their mouth,
mhm.
blowing oxygen into their face. So just trying to get them through it.
Right. I mean, it's clearly very specialist, and I think as UK residents, we're very lucky that this is available, and surgeons like you are trained here and operate here. What's that like for other parts of the world? Is this are we in the UK? Are we ahead of this? Are we kind of similar to other parts of the world? I assume there are some parts in the world that don't have this as an option. Are there movements towards bringing that more to more parts of the world as well?
Yeah. So I mean, obviously that healthcare is a very hot topic certainly in the UK, and I think the media in the UK will give a very bad impression of our state of healthcare. So patients are often amazed when they do suddenly get this sight-saving treatment so quickly. They weren't expecting that. They didn't think the NHS could provide that. So
Mm,
we are in a really good position, I think. It does cost a lot of money to provide this service, and of course, there's a lot of health inequality around the world. Uh, Western Europe and Antipodes do fantastically well. I actually did some training in L'Hôpital Jules Gonan. So Jules Gonan was the first ever retinal detachment surgeon in Lausanne in Switzerland, and Switzerland being an extremely wealthy country
mm,
has got incredible resources. Um, but then you look at other parts of the world and you just see such mass inequality. Even wealthy countries like the USA. Now, I haven't worked there, but you are aware that there are challenges for some people to access healthcare because of financial constraints. And then, of course, we have the truly poverty-stricken parts of the world. And I've got a couple of friends and colleagues that work and live in sub-Saharan Africa, friend of mine from training, was originally from Ghana, did all of his training in the UK. He was he is a fantastic person. And he could have got any job he wanted in the UK, but he went home and set up the first vitreoretinal service in Ghana.
Mm.
And just to, hats off to him, just an amazing guy, the work he does. But we know that in those parts of the world, patients will often present very late because of not knowing what the problem is, difficulties reaching healthcare, just geography, not being able to travel. He works in the capital city, Accra, but that's the only place you can go for VR surgery.
Yeah.
So it's very difficult, and so he's clearly very experienced in complex surgery, because when pathology diseases present late, they are more difficult to treat. The outcomes are worse for the patients. What I would say is that any move to expand VR surgery, because there are probably quite a few countries in sub-Saharan Africa that don't have any VR surgeons, but it has to be fully invested, sustainable, and not just popping in and making yourself feel good for a few weeks and fixing some eyes and then going home again. It has to be a full health infrastructure to deliver that care.
Yeah.
And that's the real challenge.
Yeah, I can imagine. We spoke briefly on the, well, you mentioned also that there was continuous improvement on procedures and ways of doing it, techniques, and obviously instruments, I would imagine, as well. If you were to look ahead for the next 5-10 years, what is going to happen? Can you kind of estimate how this area will advance? And I'm thinking also perhaps around the kind of robotic surgery that we see for other things, where the surgeon is in the UK and the patient is in the US, or the other way around, or whatever it might be, where it's kind of operated like that. Is that something that would even be possible? And where are we going with the technology?
So I'll start with the robots, perhaps. It's always a fascinating topic, robots. There are some very clever academic VR surgeons around the world who are using robots.
Right.
It's for a very specific indication at the moment, I think. So what we do as VR surgeons has typically got pretty good outcomes, and what I do day in, day out, I can't see at the moment how a robot can improve on that. And I think that that's unlikely within my lifetime, within my career at least.
Mm-hmm.
But the robots are being used to inject gene therapy, blebs of fluid under the retina. And this is a volume of liquid of about 0.05 mils that has an approximate cost of about £300,000 for that drop of fluid. So with that, you can see how it's really important to get that drop in the right place.
Yeah.
And that's where robots are being used. My understanding of the I think handful really of true academic experts in this field globally that's the primary sort of target. They are using it for other things. It's an experimental stage. So I feel safe in my career for now that I'm not going to be taken over by the robots. But who knows where it'll lead to? It's impossible to say.
Yeah.
As for the question about being operated in a different country, I mean, if we think about what I was saying earlier about the patient's anxiety, and part of the success of the surgery is that personal interaction with the patient, because it's teamwork, really. They have to be fully on board with getting their eye fixed and letting you do it and trusting you to do it. And I don't think a robot's quite as reassuring. I don't know, maybe it is more reassuring, but I wouldn't find a robot as reassuring.
No.
Sometimes even just the surgeon, a gentle hand on the shoulder or on the forehead where I'm operating, and there's enough to get them through the surgery.
Yeah, no, it's fascinating, and it's such a specialized field that I think that hopefully we've been able to answer lots of questions, but we're not quite done yet. And I do want to talk a little bit about general eye health and any recommendations you might have for all of us to say, well, actually, do this in order for us not to have to come and see you. We don't want to put you out of a job, but general eye health. Any advice you can give us on that one?
So general eye health. There is the saying that the eye is the window to the soul, I think, and the eye is a reflection of that means really that the eye is a reflection of your overall bodily health. Okay, so I do. It's not an uncommon question to be asked, and really, the better you look after yourself, the better your eyes are going to be. And so my standard advice to any patient that asks me that question is just look after yourself, do exercise, so your cardiovascular system is working well, eat a good diet. And we know that lots of green leafy vegetables, for example, can protect you from macular degeneration, which is a condition that is a significant cause of vision loss. And smoking, actually, I'm not one to go on about smoking, but smoking specifically does make macular degeneration worse, for example.
Right.
So that's sort of general ophthalmology. In terms of retinal detachments and vitreoretinal surgery, I would say actually there's not a huge amount that can be done to prevent the majority of situations. Trauma plays a small part in the VR surgery. So safety goggles for those that work in dangerous environments, safety goggles for all children that carry pencils, but that might be stretching it a bit too far. The two biggest injuries I think we see in the sort of general ophthalmic A&E, the eye A&E, I can think of not necessarily requiring surgery, but certainly that putting their eyes at risk are, depending on the age of the patient, Nerf gun injuries. So to all parents, don't let your children fire Nerf guns in each other's faces, okay? Nerf guns can be fun, but only if done sensibly. And then the other one is champagne corks.
Right.
So shaking the bottle of champagne and looking down at it as the cork flies up is a nasty cause of injury. Similar to squash balls as well. They fit very well inside the eye socket and can cause significant compression injury.
Right.
And then perhaps the final group is patients with diabetes. And it's a condition I see a lot of, where diabetes is a silent condition. It doesn't cause any symptoms at all. So it can often be ignored. But it is causing gradual damage to the eye and eventually can cause severe vision loss. So it's a very specific cohort, of course, but all fits in with looking after yourself, looking after your body.
Yeah. Well, thank you for that. And I think probably some that aren't particularly obvious, like squash balls and, I mean, Nerf guns. You can see exactly what would happen. Whether that's always considered is another question. And I've probably fallen foul of that at times as well. But this has been really insightful and really interesting. And thanks for joining. We're not quite done yet, though, because I did ask you to prepare the Virtually Anything Goes question for our new listeners. This is where Andy gets to ask me a question. I've asked plenty of questions today. I don't know what the question is, but it can be anything, any question on any topic. Yeah. And I have to answer it no matter what. The only caveat is that once I've given my answer, Andy then has to also answer the same question. So the control is in your hands, Andy. Fire away.
Okay, so I get a little bit of background. My wife is reading a book by Professor Steve Peters called The Chimp Paradox, right? It's about all of us controlling our inner chimp, which is the kind of bit of our personality that we struggle to control. Now, Lev, of course, we are also not just podcast friends, but we actually know each other in real life as well. Yeah. And you are perhaps one of the calmest, most measured people that I know. My question to you is, when was the last time, or can you think of a time when you've been angry at something, but there's a caveat, I'm afraid, you're not allowed to use your children as an example. Okay. So when were you angry and what were you angry about? How about that?
Oh, good question.
Because I can't imagine you being angry.
Well, I do get angry. I'm trying to think when the last time was and what it would have been. Might have to edit out the long pause here. That's a great question.
This can be edited, right?
Yes, it can be, and probably should be. It might take me a little while.
Do you want to go and make yourself a cup of tea? And then,
last time, you see, I don't really get sort of apoplectically angry, where it's just loss of all senses and control.
No, I know that. I can't imagine that.
I was incredibly angry to the point that I felt like writing a letter, which I rarely do, to our local MP, because the other day I was driving around the car and I had felt the car just being a bit swayed. It felt like it was on water. And I thought something clearly is wrong with it, so I took it to the garage, and in fact, the MOT was due, and they called me saying it had failed, and I thought it was the windscreen wiper that had come off slightly. And they said, no, this is the front suspension is completely shot. And I said, oh my gosh, okay. So they had to change it, and they said they showed me the kind of the suspension which wouldn't move at all, and then the kind of roll bar which was completely bent. And they said it must have been a pretty high impact. And I thought, well, no, I can't remember any high impact. And I checked with my wife just in case, and she said she hadn't driven the car in a while, so it clearly was something to do with me. And I just couldn't think back what it was, because I'd only felt it for the last 2-3 weeks. But the only thing I can remember is a ginormous pothole at the back roads where we live, which was during the winter covered in just a sort of, looked like a small puddle. And I went through that and I heard a huge, tremendous bang. So potholes make me very angry, and just generally the state of repair of our roads in the UK. And whenever I drive on a road that's been freshly tarmacked, it just stands out. I think this is what it should be like, and but 99.9% of roads aren't like this. So that makes me angry, to the point that I have considered writing a letter to the local MP. Probably that's probably how the most angry I get. If I think of anything else, we'll edit this in afterwards.
That's a great example.
What about you? I have to put this question back to you now.
Yeah, so I think I like to think of myself as also being, try to stay zen, and not get too angry about stuff, because most things don't matter that much. But again, it's talking to my wife that I realised that some things are just out of your control, and driving to work, it comes back to cars, right? This is where cars, I think, are the problem here. Driving to work, you set off at a good time to be at work, plenty of time. And yet there might be a bit of bad weather, and all of a sudden things slow down, and then the traffic stops on the motorway. And then there's some cars that have spun out of control. But before I get to that stage, I get angry. And then I realise, I have to talk at myself. Think, you can't be angry about this, because this is just life. Life's not fair. And also, I'm only going to be late for work for 20 minutes or half an hour. And somebody else might be having something really awful happening in their lives. So it's just a note to myself to stay zen and remember that as long as, the outcome for me is really not that bad. I might just be a bit stressed at work for an hour or so, which is okay. I can handle that. Whereas somebody else might be having the worst day of their lives. So just keeping things in perspective. And that helps to control that inner chimp and put it back in the box.
No, it's a great question. And as you say, I think there's a lot of things that will make us angry, but actually observe from space, it's probably pretty minimal, isn't it? Probably.
It just doesn't matter, does it? These things don't matter.
No, be more chill, be more zen, and
exactly.
Live life. Fantastic. Look, Andy, this has been a really, really interesting conversation. Really enjoyed listening to the insights you gave, and I hope the audience will agree as well. It's not something that we typically come across, and for the first 5-10 minutes of you explaining the kind of the stuff that you do, I was clenched sort of all over and wincing internally, but actually it is fascinating, and it is reassuring that this is available, and it's something that can be done quite quickly, as you mentioned. We don't have to wait a long time for this kind of things when it's an emergency, so or for any time for that matter. But we appreciate you being on and sharing this insight with us, and it's a view into an area that we don't often get. So thank you for your time, and thank you for talking to me.
Well, I'm really grateful for you inviting me on the podcast, Lev. As I said to you before, I was a little bit anxious about this, but it's been great fun. And also your questions have been really insightful and show, I think, just great questions, really probing this whole field, which I love. So thank you so much for having me.
No, you are welcome. And I can't see how you could be anxious about this when you operate for 9 hours a day on eyes with small instruments. So, but no, it's been brilliant.
That's easy.
And thank you to all of you for listening as well. If you like this episode, there's plenty more. Like and subscribe this one and share it with others. Spread the word and spread the insights and interesting conversations. So thanks for listening, and we'll see you in the next episode.
Thank you. Bye.